Hi, welcome to the next section of our presentation. For this section, we'll be going through some general guiding principles for managing ICU patients. I think we have gone through quite a number of specific topics in ICU care. For example, mechanical ventilation, how to manage hemodynamic instability. So we thought we just round off these series of presentations with this last section, which is surviving the ICU round. So importantly, there are what we believe are some guiding principles of providing good ICU care. And we all know ICU cases can be very complicated for some patients. Really, the management principles of ICU patients are not that much different from cases in the general ward. One useful approach is actually to identify what is actually the main mechanism of deterioration in terms of physiological deterioration that brought a patient to the ICU. For example, is this predominantly respiratory failure or hemodynamic instability, or say a poor GCS that brought the patient to the ICU, and then start to work from there to try to figure out how to reverse this physiological deterioration. While we perform resuscitation for many of the ICU patients when they first touch down to the ICU, concurrently, we are also actively working to develop a diagnosis, a likely diagnosis or working diagnosis. Of course, there may be more than one diagnosis that led the patient to the ICU. And of course, these working diagnoses can clearly evolve as more information comes in. And therefore, it's very important to monitor the response to what we believe is appropriate treatment. If the patient does not respond appropriately, then we have to start to think of an alternative diagnosis. And therefore, lastly, it's very important to always consider a wide range of differential diagnosis for any ICU patient. Another key component of ICU management is also to try to avoid as much as possible so-called complications of ICU management and morbidity associated with ICU care, because clearly many treatments and procedures in ICU are associated with complications and risk to the patient. So what are some of these possible comorbidity and complications of ICU care? One of probably a common complication is the procedures done on patients. So patients can have bleeding or injury to vascular structures from a central line insertion, for example. If these patients receive propofol in high doses for prolonged periods of time, or if they have citrate dialysis, then they can have complications from these medications, such as metabolic acidosis. Clearly, ICU patients are at a higher risk compared to other patients for getting nosocomial infections. And these organisms often are drug resistant because of lines that we insert for the patients, and also ventilator-associated pneumonia. Critical illness and immobility, of course, predispose these patients to venous thrombosis as well. They are clearly at an increased catabolic state, so we have to watch for nutritional intake. Pain, agitation, and delirium is very, very common and often under-recognized in many of the ICU patients. And last but not least, deconditioning from critical illness, polyneuropathy, or myopathy. So during the daily ward rounds, I suppose, every day we have to actively visit what are the possible issues, likely diagnosis for the patient. And often if you round in the ICU, we often cover our plans and issues going by systems. So for example, we look at the neurological system, the cardiovascular system, the respiratory system, so on and so forth, and try to identify what the issues are and what the plans are for the day. Very importantly, as mentioned earlier, we need to always monitor the response to all these treatments that we are giving and make sure they are improving with treatment. And lastly, also to remain very vigilant for new issues that may arise during the ICU care. And of course, the basis of all this is a good clinical history, and also physical examination is actually very important in the ICU, looking out for complications from line insertions, looking for possible infections from from existing lines. And also, of course, patients in ICU often are sedated and can't complain of pain, for example. So we have to be vigilant for things like an acute abdomen or a distended bladder, for example, that the patient may not be able to complain about. Of course, communication with other disciplines like nurses, allied health, and subspecialties are key. And also, family communication is very important in ICU, especially so for patients who may be isolated, considering the current COVID pandemic. Family members are not allowed to visit this patient, so I think it's very important to maintain good communication with the family. Last but not least, good and accurate documentation is also extremely important in the ICU. So to kind of avoid or minimize complications while caring for these patients in the ICU, many ICUs around the world have protocols to address on a daily basis. So this is one very commonly used one called the FASTHUG BID. I believe many of healthcare workers who have worked in the ICU before are probably quite familiar with this. And I think for the rest of the presentation, we'll take just a little bit of time to go through each component. So firstly is feeding. Essentially, whenever there's a patient who comes to the ICU, the first question is, can we feed the patient? It's important to make sure that the patient is stabilized first before initiating feeding. Make sure there are no contraindications. If the patient is still very significantly hemodynamic, has very significant hemodynamic instability, and still resus is ongoing, then there's no urgent need to initiate feeding. Of course, if the patient has an intestinal obstruction, for example, then clearly feeding should not be initiated. But otherwise, we do like to initiate early, i.e. within 48 hours of critical illness, initiate early nutrition, and usually we prefer the anterior route rather than total parenteral nutrition or TPN. And usually we don't commonly start TPN, especially if it's still within the first 1 to 2 weeks of ICU stay. Of course, in patients who are malnourished and you anticipate that it's very unlikely that they will be able to tolerate anterior nutrition, then TPN can be considered early. There is no need to reach target goal rapidly within the first few days of ICU care. And often we start with so-called trophic feeding, meaning something like 8 to 10 kilocalories per kg per day, rather than escalating immediately to target feeding, which is commonly quoted as 25 to 30 kilocalories per kg per day. Importantly, protein supplementation is something that we should keep in mind. Usually for critical ill patients, we aim roughly about 1 to 1.5 grams of protein per kg per day. And during the course of feeding, it's important to monitor feeding intolerance as well. There are a number of enteral formulas that are available. So the choice of enteral formulas can depend on the patient's condition. For example, if there's a need to give low potassium or low phosphorus formulas such as nephro, especially for patients with end-stage renal failure, advanced chronic kidney disease. And also, nephro has higher calorie content, so you can fluid restrict these patients more easily as well. Other formula, for example, Gravity has more fiber and therefore is a bit better for patients with diarrhea, so on and so forth. So the next part is A, which stands for analgesia. And I believe sedation and analgesia has been covered previously, so I'll very briefly run through. Pain control is something that's often missed in ICU patients. And it's very important to address pain adequately because these can lead on to delirium and worse outcomes for our patients. And clearly there are many causes of pain or discomfort in critically ill patients. And things like a visual analog scale or other behavioral indicators like this critical care pain observation tool can be used to assess patients. Although there are many medications we can use for pain control, usually in the ICU, IV opioids is first line, and very, very commonly we use fentanyl. It's fairly short acting, less histamine release compared to other forms of therapy and less dependent on renal or hepatic function as compared to, say, morphine, for example. The next is sedation. And sedation is something that is very important to consider in ICU patients. It's important for comfort and sometimes also for other indications like to reduce ventilator dysynchrony, or if the patient needs to be paralyzed for severe ARDS, for example, then it's important to sedate these patients. However, having said that, usually for ICU patients in general, we prefer not to deeply sedate these patients. There is this RASS, or Richmond Agitation Sedation Scale, that you can see here below, and we generally try our best to aim for a RRSS score of about 0 to -2. So i.e., ideally they should be alert and calm, if not then lightly sedated. We try to avoid benzodiazepines, and we prefer very much to use non-benzodiazepines such as propofol and Precedex, for example. Thromboprophylaxis is sometimes can be forgotten when there's many patients in the ICU, but it's also something that's important to take note. We usually tend to prefer pharmacological thromboprophylaxis with Clexane, and an alternative being heparin, especially for patients who you may be worried about bleeding issues, because heparin is shorter acting, can be reversed as well, much more efficiently than Clexane. But otherwise, Clexane is usually what we give in ICU. Take note there should be dose adjustment if there's any significant renal impairment. Alternatively, if the patient is not safe to administer these anticoagulants, then non-pharmacological options include things like an intermittent pneumatic compression. Next is head of bed elevation, ideally more than 30 degrees, and essentially the idea is to hopefully reduce the risk of ventilator-associated pneumonia. But keep in mind that there are many other ways of reducing the chance of getting a VAP, and the very important one is to consider readiness to extubate on a daily basis. So essentially, the patient does not need mechanical ventilation or any airway protection, then we should try to extubate if it's safe to do so. And spontaneous awakening trials and spontaneous breathing trials are recommended in most ICUs to assess readiness to extubate. Other things include early mobilization and, of course, to change the ventilator circuit if needed to reduce the incidence of VAP. Stress ulcer prophylaxis is often given with PPIs, so IV omeprazole or oral esomeprazole. An alternative is histamine 2 receptor antagonist, although the evidence is slightly marginal in favor of PPIs. But also, if the patient does not need prophylaxis, then we should not be giving PPIs for every patient, because there's some evidence that PPIs may increase the risk of nosocomial pneumonia. However, in patients with clear risk factors, if they are on mechanical ventilation for more than 48 hours, they are coagulopathic, there's presence of GI ulceration or bleeding in the past year, patients with severe burns, traumatic brain or spinal cord injury, then these patients should receive PPIs or stress ulcer prophylaxis. Other risk factors include severe septic shock, sepsis, if patients are on long-term glucocorticoid therapy or antiplatelet therapy. Then stress ulcer prophylaxis can also be considered. Glycemic control, we do not like hyperglycemia because hyperglycemia has been clearly shown to be associated with poor outcomes. Whether this is causative in nature or just an association is still unclear, but we try to avoid hyperglycemia if possible. However, the optimal blood glucose range is still very controversial. Most evidence seem to suggest that a very tight glucose control, aiming between 4 to 6 millimoles per liter, has no benefit, but instead possible harm, with some large studies even showing increased mortality and higher incidence of hypoglycemic episodes. So generally speaking, in most ICUs, we aim for a fairly conservative glucose level of about 8 to 10. And to control these glucose levels, we prefer to use short-acting insulin rather than long-acting agents. Lastly is BID, which stands for bowel movements. So it's important to monitor for diarrhea, which can be due to C. diff colitis. And also review the indwelling lines and catheters daily, because if they are not needed, then we should remove them. The femoral side central lines are associated with a slightly higher risk of infections, and therefore, if not urgently needed, then we should try to go for the internal jugular vein if possible. But of course, sometimes if the patient needs to be urgently resuscitated and is critically ill, then we may insert a femoral line just to get IV access rapidly. And lastly, de-escalation of antibiotics is also important in our patients. So in conclusions, I guess the general principles of ICU care, again, it's not that different from general ward care. It's really to always keep revisiting the issues and diagnosis based on the clinical progress, to monitor if patients are responding to the treatment, maintain or rather consider a wide range of differential diagnosis. And ICU care is also multidisciplinary in nature, so it's important to maintain good communication with nurses, with other subspecialties, and of course with the family members. Be mindful that ICU care is definitely not, definitely associated with complications, with morbidity. So it's important that during our daily rounds to look out for complications, be vigilant for nosocomial infections or other complications of treatment. And one of a nice way to monitor, remind ourselves to monitor for these complications is FASTHUG BID, which I just went through. Okay, thank you very much.